Effective January 1st, 2021, CMS is aligning evaluation and management coding with changes adopted by AMA CPT Editorial Panel for Office Outpatient EM visits. This new Evaluation and Management Services Guide affects CPT codes 99201 to 99205 and 99211 to 99215. EM Office Outpatient visit codes for new patients are reduced to 4, while 5 levels of coding are retained for established patients. 99201 has been deleted. The CMS Patients Over Paperwork Initiative streamlines regulations to reduce healthcare providers' administrative burdens to decrease unnecessary documentation. In other words, to increase efficiency and avoid what is known as note bloating. CMS now requires history and exam only as medically appropriate for all levels of EM coding. This means you need to focus only on the medical decision-making component to determine the level of your visit. Clinicians now need to document only interim or pertinent history and relevant physical exam findings. Another welcome change is that CMS will now allow the use of documentation of chief complaint or history of present illness recorded by ancillary staff or provided by the patient itself. This is a boost to team documentation efforts, as your medical assistant could help with the documentation of your visit notes. With this simplification of the guidelines, clinicians now have only 2 options to choose from when deciding how to select EM visit levels, either by determining the complexity of the medical decision-making or based on time. When using time for code selection, it is important to shine some light on another change in the rules. Before, a healthcare provider could only use time for billing if the encounter was dominated by counseling and/or coordination of care. Now, time may be used to select a code level whether or not counseling and/or coordination of care dominates the service. This is not limited to the face-to-face encounter. It incorporates the total time on the day of the encounter. This includes pre-charting, talking to family or caregiver, and time spent on documentation, even pajama time. Coding by time is very straightforward. However, it is to your benefit to learn how to code outpatient visits based on the complexity of your medical decision-making instead of relying just on time. The time it takes to complete a high-level medical decision office might be less than the time required to bill for the same visit level based on time. Therefore, having a good understanding of how to appropriately document a visit to code and bill based on the complexity of your medical decision-making can result in a higher level of compensation. When coding based on medical decision-making, there are 4 types of medical decision-making to choose from: straightforward, low, moderate, and high. Each one of them correlates to a visit level. There are 3 key components or elements to consider in selecting the medical decision-making level: problem complexity, management risk, and data. Only 2 out of 3 elements must be met to reach a medical decision-making level of complexity. For example, if your documentation of the visit has minimal or no data reviewed, but it does have a moderate number and complexity of problems addressed, and a moderate risk from additional diagnostic tests or treatments, then this qualifies as a moderate level of medical decision-making, and you can select the 99204 or 99214 code, depending on if the patient is new or established. Medical decision-making depends on 3 elements: number and complexity of problems addressed at the encounter, amount and/or complexity of data to be reviewed and analyzed, risk of complications and/or morbidity or mortality of patient management. There are subtle but significant changes in the definitions of these 3 elements compared to the previous guidelines. The switch was made from diagnosis to problems. Data is now expected not only to be reviewed but also to be analyzed, and the risk of complications, morbidity, or mortality are derived from the management of the patient instead of from the patient problem itself. Let's review each element of medical decision-making in detail. Number 1. Number and complexity of problems addressed at the encounter. This element is probably the most important one. It can be classified as minimal, low, moderate, or high. This classification is based on the number of problems addressed at the encounter and their complexity. For example, a chronic illness with severe exacerbation is more complex than a stable chronic illness. The following are examples of each level of complexity. Minimal complexity. One self-limited or minor problem. For example, a cold, an insect bite, or tinea corporis. Low complexity. Two or more self-limited or minor problems. One stable chronic illness, for example, well-controlled diabetes or hypertension, a cataract or BPH. One acute, uncomplicated illness or injury, for example, a UTI, allergies, a simple sprain. Moderate complexity. One or more chronic illness with exacerbation, progression, or side effects of treatment. Two or more stable chronic illnesses. One undiagnosed new problem with uncertain prognosis, for example, a breast lump. One acute illness with systemic symptoms, for example, pyelo, colitis, pneumonia. One acute complicated injury, for example, head trauma with brief loss of consciousness. High complexity. One or more chronic illnesses with severe exacerbation, progression, or side effects of treatment. For example, an MI, a pulmonary embolism, or severe respiratory distress. One acute or chronic illness or injury that poses a threat to life or bodily function. For example, multiple trauma. To help avoid any confusion when determining the complexity of a problem, the AMA published a document with the coding guidelines changes that provide detailed definitions related to the medical decision-making elements that have a more clinical, intuitive context. It is a good reference to use when there is a need for clarification. Medical decision element number 2. Amount and/or complexity of data to be reviewed and analyzed. There are 3 data categories: tests, documents, orders, or independent historians. Independent interpretation of tests. Discussion of management of test interpretation with an external physician or other qualified healthcare professional or appropriate source. This element, in our opinion, is the most complex, as it has many variables you need to calculate. It is probably the least important to remember. If you ever need to calculate your medical decision-making level based on data, make sure you reference the AMA document we mentioned earlier. You can find a link to it in our article. The takeaway point is that you should document anytime you review and analyze a test, a note from an external source, when you obtain history from an independent historian, when you provide an independent interpretation of a test, or when you discuss the management or test with another healthcare professional. Medical decision-making element number 3. Risk of complications and/or morbidity or mortality of patient management. This element, in combination with the problem number or complexity, is usually the de facto duo used to calculate the medical decision-making level. The element has 4 levels: minimal, low, moderate, and high. Each element has a direct correlation to the degree of risk of morbidity from additional diagnostic testing or treatment. For example, no treatment will have a minimal risk. Over-the-counter drug should be low risk. Management using a prescription drug or whether or not a patient should have surgery might be considered moderate risk, while deciding that the appropriate management for a patient in your office is to have emergent surgery or hospitalization should be considered as a high-risk management, as there is a high risk of complications and morbidity or mortality in such given cases. If all this information is too confusing, just use your common sense when deciding your level of decision-making. You can use the following rules of thumb. If it only needs a Band-Aid, then code straightforward. If all it takes is a Tylenol, then code low. If you need to send a prescription drug, then code moderate. If you need to call 911 to take them to the hospital, then code high.